Good morning, everyone, and thanks again to the organizers for inviting me to speak at this great meeting. I've been asked to sort of give an update on CAR T-cell therapy, and so I'll focus on the clinical data that's been presented publicly to date, and then also been asked to give a little perspective about whether this could be a possible cure for myeloma, so I'll get a little more speculative at the end. Okay. So we heard a little bit already from David Avigan's talk about what a chimeric antigen receptor is. This site basically combines a recognition domain of an antibody with the signaling domain of a T cell, and then uses a gene transfer technique to stably express this novel receptor in patients' immune cells, typically T cells, but this has been done with NK cells as well. And this confers novel antigen specificity to these cells. And the addition of co-stimulatory domains such as CD28 or 4-1BB really enhanced the expansion and persistence of these cells in patients and really led to this era of seeing great clinical results with these CAR T cells. And this has primarily been seen with CD19-directed CAR T cells, now with FDA-approved products for both ALL as well as diffuse large B-cell lymphoma. Now, in multiple myeloma, there are a number of potential targets for CAR T cells. You have what I call the classic antigenic targets that have been known to be expressed on plasma cells for many decades, although many of these, such as CD138 or 38 or 56, are expressed on other normal tissues of the body as well, which leads to some concerns about toxicity. There are a number of newer antigens that have been identified that may have somewhat more specific expression, and all of these have demonstrated at least preclinical activity and in some cases clinical activity using CAR T cells in myeloma. The one that's sort of the furthest along that I'll be focusing on is the BCMA target. And so BCMA stands for B-cell maturation antigen. This is a cell surface receptor. It has two known ligands, BAFF and APRIL. And together with these ligands, the normal function of BCMA is to regulate long-lived plasma cell homeostasis. And BCMA knockout mice can have normal survival, can generate a primary immune response, but don't generate long-lived plasma cells. And this is a nice target because outside of plasma cells, it's really only on a small subset of post-germinal center B cells and some plasmacytoid DCs, but not on other normal tissues of the body. BCMA is highly expressed on myeloma cells. However, the intensity of expression can vary from patient to patient. And it can be measured either by immunohistochemistry or flow cytometry. And BCMA also can be cleaved at the cell surface by a gamma secretase complex, and this leads to a soluble form that circulates and can be identified in patients' serum and often is a marker of tumor burden and has prognostic impact as well. Importantly, some nice work done from Ken Anderson's lab. BCMA signaling actually can promote myeloma pathogenesis. And so if you knock down BCMA in myeloma cells, you induce apoptosis. If you force overexpression in myeloma cell lines, you get a more proliferative tumor. And so for all these reasons, this is a good target for immune therapy. And as we've heard, this is not just a target for CAR T cells, but for antibody drug conjugates and bispecifics, all of which have now entered the clinic. So the first group to actually generate and test a BCMA-specific CAR in myeloma was Kokendorfer and colleagues from the NCI. And they used a CAR that had an anti-BCMA scFv derived from a murine antibody. It had a CD28 co-stimulatory domain and was packaged in a gamma retroviral vector. And in this first-in-human study, they gave a single infusion of autologous CAR T cells after Cytoxan and fludarabine conditioning, looking at 4 different doses. And what they saw in this early experience were that, especially at the higher doses, they started to see clinical activity, including some deep responses in patients. This was associated with the degree of CAR T-cell expansion, as well as with the same types of toxicities that had been described with CD19-directed CAR T-cells, namely cytokine release syndrome, and in some cases, neurotoxicity. And this group recently presented and actually just published a couple months ago their updated experience in this trial just at the highest dose level of 9 million CAR T cells per kilogram. These were 16 relapse refractory patients, median of 10 prior lines, so very heavily pretreated. There was some selection for this trial. You had to have at least 50% BCMA expression on the myeloma cells by immunohistochemistry, so this excluded up to 1/3 of patients that were screened. And in this subset, they also excluded patients with higher tumor burden, more than 30% plasma cells, in an effort to limit toxicity, so somewhat selected group. Nonetheless, what they demonstrated was confirming the initial experience, showing high response rates in this group. 13 out of 16 patients responded, including many VGPRs and CRs. This included clearance of the bone marrow in most evaluable patients, and a median event-free survival of about 7 to 8 months. So there were some patients who had durable remissions longer than a year, but most of the patients ultimately relapsed. The second study that's been presented is our trial from Penn. This is using a CAR that was developed in collaboration with scientists at Novartis. This is a fully human BCMA targeting CAR with a 4-1BB co-stimulatory domain packaged in a lentiviral vector. And in this study, we looked at 3 different cohorts of patients. The first was just using CAR T cells alone without any lymphodepleting chemotherapy at a dose of 1 to 5 times 10 to the 8th CAR cells. A second cohort added cyclophosphamide as lymphodepletion with a 10-fold lower dose of CARs, and then the third cohort was the Cytoxan with the full or 10 to the 8th dose of CARs. We gave the CAR cells as a split-dose infusion over 3 days, and there was no pre-specified BCMA level required for eligibility. We subsequently amended the trial to expand all 3 of these cohorts to get a better sense of safety and efficacy both with and without lymphodepleting chemo, as well as at the higher and lower dose. And the primary objective was safety, with the number of secondary and exploratory objectives shown here, including the ability to monitor the CAR T cell expansion and persistence by flow cytometry and PCR. This also was a heavily pretreated group of patients with median of 7 prior lines of therapy. All but 1 were dual refractory to a proteasome inhibitor and IMiD, and close to half were quad or penta refractory to 2 PIs, 2 IMiDs, and daratumumab. The majority had at least 1 high-risk cytogenetic feature, and 2/3 had deletion 17p or a TP53 mutation, and tumor burden was relatively high. And within the 3 cohorts, they were relatively well balanced, with the exception of somewhat higher lines of therapy in the first cohort, more dara refractory patients in the third cohort, and slightly lower tumor burden in cohort 2. So in terms of clinical activity, we actually somewhat surprisingly saw responses even in the first cohort without any lymphodepleting chemotherapy, with 4 out of 9 subjects having an objective response PR or better, including our first patient who had a stringent CR that was still ongoing over 30 months after infusions. In the second cohort, where we used the 10-fold lower dose of CAR T cells and added cyclophosphamide, the activity was less robust, with only 1 objective response, and this cohort was closed early. And in the third cohort, using the cyclophosphamide and the fuller or higher dose of CAR T cells, we saw 7 out of 11 subjects respond, including 2 ongoing responses now over a year. And so overall, the responses were seen in about half of patients. However, like the first trial, the majority of these responses were not durable long-term, with a median duration of response of about 4 months. The third study, which we heard a little bit about in one of the earlier presentations, was the Bluebird trial using the BB2121 CAR. This actually uses the same scFv that was in the original NCI CAR study, but switches out the co-stimulatory domain for a 4-1BB domain. This was given as a single infusion after fludarabine and cyclophosphamide conditioning. Initially, again, a dose escalation portion in patients who did have to have a set level of BCMA expression, and then an expansion portion using just higher doses, 150 to 450 million CAR T cells, which allowed both low BCMA expressors or high BCMA expressors to get in. And updated data was presented by Nupa Raji at the ASCO meeting earlier this year on this study. Again, heavily pretreated patients, median of 7 to 8 prior lines of therapy, about 2/3 dual refractory to bortezomib and lenalidomide, and about 1/3 were penta refractory to the agents shown here. And what they demonstrated was that there seemed to be a dose-response relationship. So at the dose of 150 million CAR T cells, the response rate was about 57%. But at the higher doses, 450 or above, the response rate was 96%, including half the patients achieving a CR or stringent CR. And this included patients who achieved MRD negative disease, although this was a relatively insensitive threshold of 10 to the -4. Also, interestingly, the degree of BCMA expression at baseline did not seem to correlate with depth of response. They saw responders in both high and low expressors, and this is similar to our experience as well at Penn, where the level of level of BCMA expression has not predicted who's going to respond or not. And in terms of durability of response, the PFS was a bit longer in this trial, close to 12 months. This is just the dose escalation phase. For patients who achieved MRD negativity, it was close to 18 months. But again, what you notice is this pattern of continuous relapse, even later in patients after a year or more, though again, there's a subset of patients now pushing out beyond 18 months. And we hopefully will be getting an updated ASH on this trial for not just the escalation cohort, but the expansion cohort as well, who are all treated at higher doses. The final study that's presented data on a relatively large number of patients was this study from Legend Biotech, a Chinese company. This uses really a differently constructed CAR, which has 2 different binding domains to BCMA and using just heavy chains. This was a less heavily pretreated group of patients, only 3 to 4 prior lines of therapy, so I think really a different population. They gave cyclophosphamide as conditioning. And at least in this presentation at ASCO 17, there were 19 patients evaluable, and all of them had responded, including 3/4 with a stringent complete remission, and 5 of these were durable longer than a year. So we really have 4 different studies now with 4 different constructs, multiple different centers, all demonstrating really proof of principle that CAR T cells targeting BCMA can get responses even in heavily refractory patients. Now, of course, CAR T cells have their issues, as I'm sure you're all aware. The toxicities really in these trials have been similar to those described with CD19-directed CAR T cells. Tumor lysis syndrome is relatively rare, but cytokine release syndrome is seen frequently. Fortunately, low grade in most patients, but can be severe, leading to ICU-level care, though abrogated by tocilizumab in the vast majority of patients. Neurotoxicity has been described in these studies anywhere from 0 to a third of patients, again, predominantly low grade with mild delirium or confusion that's transient and reversible, but high-grade encephalopathy, including low-level cerebral edema, has been described, again, fortunately reversible in these patients. And a subset of patients have developed more longer-lived cytopenias, particularly in the trials that use fludarabine conditioning. The other issues, of course, are logistical problems with CAR T cells, limited access at only specialized centers, the need for delays for manufacturing that unfortunately leads some patients to have rapid progression and clinical deterioration and never actually get their CAR T cells, and of course the cost of this as well. Nonetheless, this early experience has generated great enthusiasm for CAR T cells in myeloma, and at least at the time I had done this search, there were at least 15 different trials that were pursuing a BCMA-directed CAR T cells. I'm sure there are more now since this is outdated. Several of these hopefully will be presenting data at ASH this year, so we'll be getting a broader experience with different constructs. This also includes a registration trial for the Bluebird construct in a multi-site phase 2. There are also now trials that have opened up hitting different targets, including CD38 and SLAM-F7, as well as combination studies with 2 different CAR products. So we'll be having a lot more data, hopefully, within the upcoming year. So I was asked to sort of comment on could this be a cure? And I think if you look at the event-free survival or progression-free survival on these studies, whoops, let's go back. The answer so far is, for the majority of patients, no. And you can see that there are a few long-term non-progressors, but the majority of patients are relapsing. We don't really have PFS data for the Legend study. So at least in this early experience in this heavily pretreated population, this may not be enough. And I think this is in contradistinction to some of the experience with CART-19, and again, recognizing the perils of comparing not just across trials, but across indications and across different CAR constructs. The key take-home here is that the overall response rates in myeloma, and even the median PFS, is not that different than what's been described with CART-19 in ALL or DLBCL. But what's different is the tail on these curves, that if patients are in a CR after the first 6 months, at least in these other indications, there seems to be more durable remissions. And this is a little different than what we're seeing in myeloma, where we're even seeing late relapses. And so the question is really why? Why aren't we seeing more durable responses, at least in this early experience? And I think there are a number of potential factors here. So there could be things intrinsic to the CAR itself, the ones that are being tested so far, their binding affinity, the particular epitopes on BCMA. The signaling domains here are really very similar to those used in the CD19-directed CAR trial, so I don't know that that's really going to be it. I think a big possibility could be the intrinsic factors in the T cells themselves. It's been known for a long time, and David Avigan showed some of this data, that there's T cell dysfunction in myeloma patients. And the more pretreated these patients are, the more dysfunctional their T cells may be. And this is something that we've observed. This is some data we'll be presenting at ASH this year. Just looking at characteristics in the apheresis product before you even start the manufacturing. And if that certain phenotypes, phenotypic characteristics can predict who may be more likely to have robust expansion or response. And so in this case, patients whose CD8 T cells had a 45RO positive, 27 negative phenotype. This is a phenotype identifies primarily naive T cells or T stem cell memory cells. If you had a higher proportion of these cells in your pheresis product before you started manufacturing, you were more likely to get better in vivo expansion and to some degree response. And then, of course, what happens during manufacturing or after the cells go into the patients may actually be important. This is data from the NCI trial where they identified significant upregulation of PD-1, a checkpoint molecule, on both CD4 and CD8 CAR T cells once they're infused into the patients. And again, whether this could be leading to early exhaustion and lack of efficacy of the cells. Another possibility, of course, is intrinsic factors in myeloma itself that may be different from the other tumor types that we discussed. This could be either factors in the tumor cell or the microenvironment. Within the tumor cell, one obvious one is the dynamics of BCMA expression. And so in our group, we've identified that BCMA intensity can be decreased on residual plasma cells after CAR T cells go in, particularly in patients who get a robust response. And this was seen in actually the majority of patients. Now, this goes back up in the majority of patients as well at the time of progression. So this isn't a permanent loss, but it suggests that there either is selection for antigen low variants that can then re-express antigen low later on, or perhaps there's increased shedding as a defense mechanism so that you have less antigen on the cell surface, and that may be a means of escape. And this has been identified in the NCI trial as well. And so I think this initial experience is promising, but really shows that we still have a ways to go. But I think we really are just in the very beginning of our understanding of how to use this type of treatment modality in myeloma. And so there's a number of ways we might be able to improve clinical outcomes, and most of these have now actually entered the clinic. And so you could optimize the CAR T cell product itself, either with dual epitope binding or perhaps dual antigen to try to avoid that tumor escape. Suicide genes and safety switches are now being incorporated routinely within the CAR, so if there is excess toxicity, you're able to shut off the CARs and have them far more tunable. Gene editing, either PD-1 knockdown, which may enhance the efficacy of the cells, or perhaps editing of MHC molecules, and the endogenous T cell receptor may allow for an allogeneic or off-the-shelf CAR to be developed from healthy donors, which gets away from that T cell fitness issue as well as the manufacturing delays. A number of efforts to try to optimize manufacturing to get more of a T stem cell memory or central memory product. Can we optimize target expression? There's a trial that's using BCMA CARs in combination with gamma secretase inhibitors to limit cleavage and perhaps maintain expression on the cell surface. Should we be selecting patients for high BCMA expression or not? I think I've shown some data suggesting this may not be necessary. What about treating earlier or in lines of therapy where patients have not had so many lymphotoxic treatments and maybe have more fit T cells? Is Cy/Flu the best lymphodepletion in myeloma? It has really sort of been adopted from the leukemia and lymphoma data. And then what are the rational combinations? And there are trials now looking at checkpoint inhibitors, combinations with IMiDs, and even with other CAR T cells as well. And so I think to conclude, what we know so far that BCMA-directed CAR T cells are highly active in highly refractory myeloma, with response rates ranging anywhere from 50 to 100% depending on the study, including MRD-negative CRs. There's a subset of patients that are durable for more than a year, but the majority are relapsing, at least so far in these early experiences, and we await the updated data from ASH to see if this is holding up. The toxicities really remain the same: cytokine release and neurotoxicity. There fortunately haven't been other off-target toxicities, but these remain significant, though we can manage them in most patients. And I mentioned the possibility of antigen escape. A number of ongoing trials are happening, including now CD38 and SLAM-F7 directed CAR T cells, combos with others, and we're awaiting these data. And I think the real challenges for us are, number one, how to improve the logistics so that we can get patients on these trials and get more patients access to this therapy, better ways to mitigate these toxicities, enhancing the persistence of functional CAR T cells. So not just are the CARs present, because we can still find CAR T cells in our patients up to 6 months, but these patients are relapsing. And so what's happening to those cells and why are they not working? And then, of course, how are we going to incorporate these with our current myeloma therapies? And I think once we overcome all of these challenges, that's when we're going to start talking about cure. But I don't think we're there yet. And I think with 8 seconds to spare, I will stop. I have just want to acknowledge all of my colleagues at Penn involved in the CAR T cell program in myeloma, and thanks for your attention.